Okay, Patty, take it away.
All right. There, that looks a little better. So in this PowerPoint, we have several of the tasks on the AR side for Matrix. And we're just going to do, this is new to some of you and review to others. This PowerPoint is available out on eSource, and I'll show you the path for that. And we'll email it out to everyone after the meeting as well. We did go over this on Tuesday, last Tuesday, with the business office staff and the executive directors. So, you know, we know that every community is different who is doing census and the month-end task. So we just wanted to make sure that we're hitting all of the targeted areas. So the first item we'll talk about is pre-admission and scheduled move-ins. So we have two types of census for somebody who is scheduled to move in or for pre-admission. And when you have a tenant that is a confirmed move-in and you're not going to charge them for rent during this time frame. So this is prior to their admission. It's a scheduled move-in and you don't plan to charge them, and that's up to the community and up to their lease agreement. So you're going to want to use that scheduled move-in and enter that in the census, and you'll use the private pay payer that's appropriate, whether it's dependent or assisted living, and then enter them into the unit, room, and bed that you are reserving. These tenants do not show up in your census reports, but they will show up on the senior living side, and that's the clinical side as a move-in. And this gives you the opportunity to start doing the assessments and to prepare for this new tenant that's coming into your building. When the tenant officially moves in, you want to enter a new census line of admission with the current move-in date. You don't want to go back and edit that scheduled move-in census line and change it to admission, and you do not want to delete that scheduled move-in line. Just leave that line as is and enter your new admission line. And then we have the other census type, which is a pre-admission. And this is the same concept, except this is when you are going to charge them for rent during this time frame. And again, that's up to the community and per the lease agreement. So you would use that pre-admission census, again, picking the appropriate payer, level of care, and room. And then again, when that tenant officially moves in, you add a new census line. And again, don't edit the pre-admission line or delete it. You want to add that new admission line when they are have officially moved in. Deleting census causes issues on the clinical side, and if Linda's on the phone, she can add to that, but it's not good. So we just want to make sure that we use the pre-admission and the scheduled move-in appropriately, and then make sure we're just adding that admission. And then you want to make sure with any admission that you're setting up the additional ancillaries that are not part of their package, such as cable, phone, and then the level, whether it's 1 through 8. Always run that charge calculator and look for any exceptions, and review the account detail to ensure that your room and your ancillary charges are now billing upon admission and to the correct payers, and that you don't have any errors. So now we'll talk about rent after discharge or expiration. So at the time of the physical discharge or expiration, put the tenant on a therapeutic leave. Use one of the following censuses below that's appropriate. So is it a therapeutic leave, the tenant's just discharged, but you're going to continue rent per their lease? Or is it a therapeutic leave, the tenant expired, continued rent? This alerts nursing the tenant is no longer in-house, but this keeps the apartment occupied for the 30 days or per the lease agreement. When the apartment is empty or the 30-day discharge is up, per the lease agreement again, enter the actual discharged or expired census line. So for those of you who have newer tenants and you're using those newer lease agreements, it talks about charging them for their rooms the 30 days after they've given notice or after the expiration. So the additional month-end tasks throughout the month you can find on the ALIL task list for communities. this is out on our eSource homepage under AR task list. Page 5 of the task list has your month-end tasks. Ensure that you're adding all of the additional services, meals, if you don't use meal tracker, meal delivery, resident assistance, LPN visit, maintenance, all of those things that happen that are not part of the tenant's package. Nursing staff should also run and review the Senior Living Extra Services report and compare it to the billing journal with the business office. So the business office should run your billing journal, as always, by level and compare the service plan levels with the nursing report, that extra services report, to ensure everyone is being billed out the correct level. So however you communicate that through the month, whether it's an email or you bring paperwork up front to the business office, make sure that all of those levels were changed. And what I would suggest doing is, just scheduling time on people's Outlook calendars the same time every month. You can do it more than once a month. You could do it bi-weekly or weekly, but just ensure that you're double checking this and that we're billing the correct levels, or even a level at all. Sometimes there aren't levels entered in on the AR side. And then make sure all of your departments are turning in billable services monthly. So whether you cut charges off on the 25th to ensure everything's out by the 31st, the centralized billing office always sends out private pay statements the last business day of the month. So you'd want to ensure that everything is entered by then.
And Patty, this is Penny. I just want to add to that. Just a reminder, it's really, again, a second reason that they should physically get together is if they're just running reports and looking at levels, Matrix cannot do a level 0. So nursing is kind of looking at that and saying, no, this is not a daily thing. This is an a la carte. So it should be on the service plan marked, but again, that's a good reason for them to do it. And I also would like the administrator, so the housing leader, to be there as well, because they're the ones making sure that all the ancillary departments are accounted for, all the like the bundles for phones and garages and things like that. So it really should be, in addition to the business office and nursing, the housing admin, just to make sure those other components that Patty talked about are buttoned up as well.
Yep, thank you, Penny, for that addition. So in 2020, the assisted livings, we implemented the use of the daily respite care. And so if this is something you haven't already set up, communities can set their rate and then file an AR support ticket for this to get set up. This runs through your census, and it's just a line that says respite, and it bills out that daily level that you computed. And then this is an example of how you can calculate your daily rate. Take your base rate plus your average of level, so the third level, and you'd take your base rent and your level and add those together and then divide it by 30 or 31 days to get that daily rate. New rate submission. So as we're coming into the new year, there are many communities who have budgeted January 1st rates. So 60 days prior, which is going to be November 1st, you'll get an email from me letting you know that you're on the budgeted rate increase for January 1st. If you don't get an email from me and you do have plans to raise your rates as of January 1st, then please reach out to me so that I can, we track these and make sure at the centralized billing office that Matrix gets updated, and also that we know who's sending out the 30-day notice, whether you're sending it out to the in people's mailboxes or we're mailing those in tenant statements. Usually I recommend doing both. Then if someone accidentally gets 2 letters, it's better than them not getting notified. So 60 days prior to the effective date of the rate increase, file a work zone request. And here's the link. And Marie Nelson will update your rate sheets. If you do not have access to the work zone platform, just reach out to Marie via email and she'll get you set up. Once received, Marie will email a copy to Penny and Linda, and they review that and approve, to make sure you have not just your rent increasing, but if your levels and all of your a la cartes, and just kind of reviewing it for accuracy. And once they are approved and you have your new rate sheet, then we want you to file an AR support ticket, and you'll pick the category rate and new and update in eSource. And this is so myself and Jackie can get your rates updated in Matrix. This step should be completed. We'd like to see it 45 days prior to the effective date of the rate change, but we understand that you're waiting for, the work zone ticket to get completed as well. The AR support ticket should also include a copy of the 30-day rate notification letter that you're sending to tenants and the instructions on who is distributing the letter. The CBO is always happy to mail that letter the last business day of the month. So again, if you're a January 1st rate increase, then we would need your letter prior to the December pre-bill on November 30th. So we'd like to get those at least a week ahead of time so we can get them printed and documented and scheduled for our billers to send out. And then you can distribute those to the in-house tenants. Like I said, a combination is usually best. Jackie and I will communicate the letter and instructions to the CBO. So please don't email your letters or your rate sheets to your biller or the supervisor. If you can file the ticket, that's where we track everything and make sure we have what we need, and then we just distribute it out to those that need it. Group residential housing. So this is for Minnesota only. So if a tenant qualifies for GRH assistance, and this is towards helping them pay for their rent, the community should set up the payer GRH assisted living. In charge entry, set up the GRH assistant amount with that ancillary for amount that they have been approved. And this is what the state is going to pay towards their rent. In the billing setup, set up a special room rate for the difference of the EW rent, which is currently $1,041, and the GRH assistance. So if they're going to pay $100 towards the resident's rent, you're going to put in a GRH assistance of $100, and then you would enter a special room rate of $941 to get that difference. And then use the private pay EW rent as the payer, like you would when they're EW. The difference will fall under private pay EW rent, and the GRH assistance will fall under GRH assisted living. But make sure that those two amounts equal the total rent. Currently, it's $1,041. And just a reminder for Minnesota only again that the designated provider form, in order to pre-bill the waiver obligation, the designated provider form must be completed. The designated provider form is only for Minnesota Medicaid. And we can never pre-bill the waiver obligation for any other payers, such as UCare, Medica, Blue Cross, Health Partners. We have to wait until we're remitted on those. So this designated provider form, again, is for Medicaid only. And if we have that on file and the resident has chosen us to be their designated provider, then we collect the full spend down or waiver obligation from them on a monthly basis. And again, communities must wait until the waiver obligation is remitted at the time, and the CBO cash poster will move it to private pay. So again, that's for any other payer besides Medicaid. We have 4 charge entries for that. So in Matrix, using the housing assisted living category, there are 4 categories. And so the community, if you have somebody on Medicaid who does have that designated provider form set up, you can use, there's a reoccurring one here, which is the second one. It takes the credit off of the waiver or off of the EW payer. And then here is the other reoccurring one that moves it to private pay. And then the cash posters at the centralized billing office would use the ones that are by occurrence on the non-Medicaid payers once we get the remit. Okay. And again, that's under the housing assisted living category. If the Medicaid tenant has a waiver obligation and has signed the designated provider form, the community again uses the reoccurring, and this moves it from the charge off the T2031 to the AL or IL private pay. And then again, the cash poster uses the by occurrence ancillaries. CADI waivers, again, this is a Minnesota reminder as well. So when you're checking eligibility and in minutes, you want to make sure you know if it's a CADI waiver or an elderly waiver waiver. And minutes, it will tell you right on the eligibility screen. So once the service agreement is received, then you would set up the appropriate T2031 in-charge entry to bill the authorized daily rate. In Matrix, you have the specific T2031 for assisted living and catered living, and then the CADI waivers. So there are T2031s that have for private pay, and then there's for elderly waiver, and then there's the CADI waivers. So make sure you're picking the right level in Matrix and identifying those CADI waivers if they are CADI. And then again, using the elderly waiver for the elderly waiver payers. This has come up a couple times, and so we've documented it in here in these instructions, just so that we always stay consistent. So if you have a second person occupant in memory care, again, this doesn't happen often, but it does happen. For private pay memory care, the memory care tenant will be the first person and be billed the full memory care rate. If the second person is an AL level of care, they will be charged the second person occupant fee plus their nursing services. If the second person is memory care, then they will be charged the full memory care level minus the annual CRP amount in Minnesota. If not in Minnesota, the regional finance director will be asked to determine the rent rate. And you'll probably have to include the regional finance director even in the Minnesota to get your CRP rate. If the second person occupant is elderly waiver, for elderly, we have the elderly waiver memory care T2031 level. The community will bill the full GRH rent and the service agreement daily rate for both the first and second person. So you would bill the 10 or the 1,041 to both of them, and then they would both receive a service agreement for their specific services. And there's no contractual adjustment for EW. Any questions on anything that we went over? I checked the chat. I don't see anything, but I'd be happy to answer any questions. Or afterwards, if you have questions and would like training on something, please don't hesitate to email myself or file an AR support ticket, and we'd be happy to go over any of these processes with you.
Okay, thank you, Patty. So that was a lot. Can you send a summary of how these charges are? Yes, so the summary and the information is on eSource. And if you want additional, questions or additional education, please reach out to Patty Olson. So I am going to, and Patty, that was wonderful. You made it very clear, but again, billing is very complex. So I know there may be some questions. I want to just make sure that we have enough time for Lisa. So I am going to ask us to hold any additional questions. If there's time at the end, we can certainly cover it. So I want to introduce, again, thank you to Patty Olson. And now just introduce Lisa. We're switching subjects here. Lisa can introduce herself as a part of our therapy team, but Lisa also has a special expertise in falls. And as you may know, Linda and I have more recently been getting more and more involved in the romp, and we are noticing that not only falls, but the creativity of what do I do about it is always a challenge for everyone. And so Lisa's insight is super helpful, and I shall turn it over to Lisa.
Thank you, Penny. Can you hear me okay?
Yes.
Okay, perfect. I'm gonna go ahead and share my screen, and then we'll get started. All right, you guys see that okay?
Yes, we can see it fine.
Okay, perfect.
And just so you know, Lisa, I did ask folks to have the bombs at least identify Patty or come to Patty's section. So if anybody falls off, that's why.
Oh, not a problem, not a problem. All right, so we're going to talk a little bit today about fall prevention, kind of cause analysis with falls, and some interventions and things that you guys can do on the housing side when someone is either identified as having a high risk for a fall or has already experienced a fall. You know, it's pretty common knowledge. We really think that falling is common as we age. But a lot of times we forget that even though we are aging adults can still improve in their strength and their balance. And there's a lot of steps and actions we can take to address the risk of falling, as well as prevention of future falls for occurring. When we look at our population specifically, an adult falls every second, older adults over the age of 65, and especially within our community. So that's a lot of falls. They lead to over 950,000 hospitalizations just within the senior housing communities alone every year, and over 32,000 deaths. So really important that we as an organization and as care providers are recognizing what we can do about falls and really how to mitigate as much of that risk as possible. So although falls are really common, what we tend to find is that our older adults might not tell us about their falls or about their risk associated with falls. Sometimes they might think that falls are just a normal part of getting older and that there's nothing they can do about it. Other times they might have really a fear that if they talk about their falls, that it could place them at risk of being put in the nursing home, or it might threaten the independence that they have. And also just the general awareness of common risk factors that put them at an increased risk for falls. For example, more than 2/3 of older adults have medications and reported use of medications that they don't know the side effects, that as we age, certain medications, the way they metabolize within our system, leads to different side effects that could increase their chance of falling. So a lot of times when we ask residents about medications, medication changes, when we're doing our risk and cause analysis after a fall, they'll just say, oh, well, I've been on that medication for years, not recognizing that with aging alone, a medication that is stable in their body might start to metabolize differently and really increase the risk of falling. So we want to start talking with our residents, not waiting for the fall to happen, but talking with them and getting comfortable about why it's important to recognize fall risk. Understanding each individual's unique fall risk, what makes a risk modifiable, and what we can do to possibly prevent a fall in the future. Emphasizing really that focusing on fall prevention helps to maintain independence. A lot of times when we start talking about falls, we get this reaction of, oh, if I talk about a fall, they're going to take away this, or they're going to restrict me being able to do that. So really changing that discussion with our tenants, with the families we have, and emphasizing that we want to be talking about fall in a preventative manner and how we can work together with different strategies to really keep individuals in our housing levels in as independent as possible situations, and developing plans that work for both the individual resident and those in their care and the caregivers working with them. So some of the things that we want to be talking about is just some simple questions. And as I said, we want to talk about falls. We want to ask our residents when they're first moving in with us, before they come to our door, maybe when they come back from an appointment. Have you fallen in the past year? Do you feel unsteady when standing or walking, or do you worry about falling? These three questions alone are some of the highest predictive positive indicators for a future fall. So somebody who has fallen in the past year is over 80% more likely to have a fall within the next 6 months. Individuals who report feeling unsteady when standing or walking are also at a higher risk, even if they've never fallen before, and even if their balance on a standardized test appears to be within a normal range. And then individuals who worry about falling, those who have a fear of falling, who worry about falling, actually start to change their mobility and movement, restrict, and actually cause an increased risk because of the way they're modifying their movement and modifying their mobility. So if you're seeing residents who are maybe changing the way that they're going through their daily routine, maybe they're changing the way that they navigate down to the dining room or come down to activities. Maybe they're individuals who would normally take the long way. They'd take a long walk, they'd go sit outside after their meals, and now they're just staying inside, going right back to their room. Start talking to them about why they've changed this pattern in their lifestyle. Are they feeling unsteady when they're standing? Are they worrying about falls? Especially as we're coming into winter, we'll start seeing kind of this decrease in mobility overall. So really having these proactive and preventative conversations can help mitigate some of that fall risk in our individuals we have on our campuses. Really important that we all use kind of the same language when we talk about falls. I'll have a slide that goes over some of the CMS and kind of regulatory definitions. But in general, when we talk about a fall from kind of that medical side of things, we're talking about that unintentional coming to rest on the ground floor or a lower surface, not as a result of an external force. So I'm not talking about when a resident runs into somebody, bumps into somebody else. Episodes where individuals lose their balance and would have fallen had we not been there, we might want to consider talking about those as potential falls, and then starting to look at what interventions could we possibly put in place to prevent a more catastrophic fall from occurring. A fall without injury is still a fall, unless there's evidence suggesting otherwise. If a resident's found on the floor, we want to assume that this is a fall that has occurred. Obviously, when we look at the difference between kind of the skilled nursing side versus the housing side, there's more details within kind of what constitutes a fall and those definitions for reporting. But when we're talking about it kind of as a community, as clinicians really looking at what can we do to mitigate risk and maintain independence, we want to make sure we're using some of that same terminology. So this whole slide, the entire PowerPoint will be available for your reference, but these are just some of the common definitions that a lot of medical providers will use when they're talking about falls. A lot of times your therapist might say, oh, well, they've had a near miss. In the therapy world, we'd still consider that a fall because it's a change in balance and interception of mobility. Falls with injury, so really making sure we're talking about as a team, what are we considering injury? And this is something that Linda will be working with you guys on with as well, but are we looking at skin tears, abrasions, lacerations, bruises, sprains, change in mental condition, or any fall related injury that causes the resident complaint of pain? So if the physician, nurse practitioner, therapist is asking, was there any injury? Those are some of the things they might be looking for when that question is asked. So just getting together as a team and really talking about, when we talk about falls, what type of definition are we using to describe what's going on with the individuals in our communities? So kind of the big important stuff. How do we prevent a fall? Can a fall be prevented? Yes, the good news is most falls can be prevented. And you guys, as the care providers, you really have a lot of power to reduce our resident and tenants' risk of falling as well as our own risk. So when we look at falls, some of the important risk factors that we want to be aware of, that we want to be talking with our residents, we touched base on this a little bit. History of falls. A year, 6 months, single most predictive factor in a future fall. If somebody comes into your community and they have had a fall in that last 6 months, you want to be talking about fall risk mitigation, what you and your team and the resident and their family are going to be doing to help mitigate a future fall. Because if they've had one in the last 6 months, they're at a very high risk for another one occurring. Using simple, effective screening criterion, quickest way to identify a potential faller. Have you fallen in the last 6 months? What is their balance confidence? And when we talk about balance confidence, it's both verbal and nonverbal expressions. So either the resident is verbally expressing that they are afraid of falling, or they're restricting some of their movement, some of their mobility, and changing their activities that they participate in. Some things we can look for as care providers, as individuals working with these tenants, whether it's the nursing staff, the resident aides, culinary, our wellness team members, looking for rigidity of movement, any body language that expresses a change in anxiety or an increase in anxiety. One example of this would be, especially in the dining area, if you have that resident who kind of does the furniture walk from their front four-wheel walker to their dining room chair, and they kind of use their hands on the table, very purposeful movement to maintain that balance. And then excessive reflexive balance reactions. So what this might be is when you're passing a resident in the hallway, they have a quick startled reaction. They grip their walker or they grab onto the side rail, put their hand on the wall or the door to steady themselves. That might be that nonverbal and body language communication that they've had a change in their confidence regarding their balance, and they are now at a higher fall risk. So when you're seeing those things, starting the conversation with our residents and tenants, hey, I noticed we're kind of startled right there. How have you been doing? Have you had any falls recently? Getting used to having those conversations with our residents and encourage them to talk with us about falls as well. Some common risk factors, and again, the more risk factors you have, the higher your fall risk. Shouldn't be new news to anybody, but some of the things we look at, as I said, history of previous falls. Age, the older you get, the higher your fall risk goes out. Medication use, multiple medications. The average resident within a Minnesota within a Minnesota housing community has over 8 medications. If they have a hospitalization, an ER visit, maybe they're being seen for some other medical reason, making sure we're aware if they've had changes in those medications, if possible. Individuals who have chronic pain makes us change the way we move and increases our fall risk. Individuals with cognitive impairment, impaired balance, and then with impaired balance kind of comes some different sensory areas. So individuals with visual impairment, somatosensory loss, or vestibular problems. Think about those residents who walk down the hallway, or you can hear coming to the dining room, you can hear them coming down to your office. A lot of times those individuals probably have some somatosensory loss, maybe they have some vestibular problems. If you can hear somebody stomping down the hallway, chances are they're probably having poor feeling, poor sensation in the bottom of their feet. So they're stomping so they can get that proprioception up to their knees. So they have awareness of where their feet are in relation to the ground and their body to maintain their balance. If you hear those stompers coming down, there's a chance that they're going to be higher on your fall risk list as well. Any decline in range of motion, strength, and power. If you have individuals who you notice are needing a little bit more assistance, if your resident aides are telling you, hey, they're needing more time to get dressed, they're just taking a little bit longer, it might be because they've had a fall they haven't told you about. They might have more fear of falling because they've had a near miss. So talking about those things with those individuals, really using these triggers to start the conversation to hopefully prevent a fall in the future. Urinary incontinence is a huge one, especially nocturia. If individuals are getting up at night, it's kind of this like triple whammy. You have a change in their environmental factor, you have a change in their visual sensory, in addition to kind of that urge and decreased safety awareness of that feeling of I've got to go. So they're rushing, poor safety awareness. So by recognizing potentially the nocturia, the urinary incontinence, we can potentially decrease the risk of falling if we treat that side of things. So looking at all of those risk factors can really help not only prevent a fall, but also look at why a fall might be occurring. So we talked a little bit about things we can do about falls. How do we recognize those risk factors? Like I said, most risk factors are modifiable. So these are things we can do something about and help to decrease the risk associated with falling. These are also things you want to look at when a resident has experienced a fall. Have they had a change in any of these risk factors? Have they had a change in their gait and balance? Do they have a medication that has a fall-related side effect? Use of multiple medications. Individuals with hypotension and hypertension, problems with feet, improper footwear. Vitamin C deficiency is a big one as well that we don't think of. Individuals who perhaps have conditions such as depression, we talked about incontinence a little bit, dementia, those increased risk factors. Obviously, there's some non-modifiables that we have to recognize. We know fall risk increases as we age. Women are more likely to fall and have injuries occur with their fall compared to men, but men tend to have a higher mortality rate related to falls than women. There are differences between race and ethnicity in regards to falls and fall risk factors, and also history of falls. That's one that we talk about quite a lot, that history of falls. So we can, as a team, kind of identify some of those modifiable risk factors and really help to put interventions both for managing and preventing future falls. That'll help to mitigate the risk of another fall occurring or a more serious risk occurring with the falls. Environmental factors. Environmental factors are a very quick and easy way we can make the resident environment safer. Some of the 5 quick tips that we talk about for preventing falls are securing some support. So this might be talking with the family about using a shower seat, having a grab bar, adjustable handheld shower heads, so making it easier to bathe and safer to have that mobility within the bathroom. Lighting, obviously we want to be replacing burnt out light bulbs, but looking at the type of lighting we're using as well, if it's an option to modify using non-glare light bulbs, blue tint LED lights, that can help to reduce fall risk. Having a seat, encouraging our residents to sit while they're getting dressed, and making sure they have a sturdy chair to sit in. A lot of times I'll go into resident and tenant rooms and they will be sitting on their 4-wheel seated walker, or they will be sitting on an ottoman that has wheels, or on a glass dining table. So really talking with them about, okay, when you're getting dressed, let's practice just sitting here, and getting your resident aides to talk about that as well, not having them stand up the entire time getting dressed, which will contribute to fatigue and then potentially increase the risk for falls when we leave the resident room. Encouraging our residents and family members just to keep things clean and clear. So removing clutter, removing throw rugs from the floor, making sure we don't have things that are moving on the floor. And just talking about that when we see our residents and tenants, asking them if they need some help to pick up, if that's something in their care plan and we can do. And then when tenants move in and we're talking with tenants and their families about how to set up their room, encouraging them to really store their items successfully. So keeping frequently used items between their waist and shoulder height. That way we're reducing the frequency of needing to stand up on our tiptoes and change our balance and our center of balance for gravity, reducing us having to bend way down low and stand right back up, potentially increasing our hypertension and vestibular risk factors. So talking with our families about those things when they're setting up their rooms as well. Therapy can help you with environmental risk factors as well. I also have a cheat sheet that we'll go over for your teams that has kind of quick checklists of risk factors for environmental things within the room and the community. Again, those 3 screening questions, getting used to just asking those questions to our residents. Have you fallen in the past year? Do you feel unsteady? Do you worry about falling? Again, answers of yes to any of these 3 questions is an indication of a potentially increased fall risk. So we might want to be doing more assessments with these individuals, whether that's referring to their physician, referring to physical therapy, occupational therapy, speech pathology to do a more comprehensive fall risk assessment and individual planning for them. Lots of things we can do in those spectrums, but this helps us to be aware of the risk of who's coming into our communities. So what do we do? So after a fall happens, this is always the big question. Fall has happened, now what do I do? Or we feel like we've done everything and there's nothing left out there. So these are just some suggestions, some ideas, some things to think about as a team, especially when you're doing that root cause analysis, trying to figure out why a fall has occurred. So these are some physical things that we notice with individuals who are frequent fallers, who are at higher risk for falls. A lot of times you'll start to see a decreased ankle range of motion. So if you know that a resident is needing more help to put on their shoes and socks, if you notice they're kind of up on their toes a little bit more, it means they're having poor range of motion with their ankles, which is our first reflex and defense to prevent a fall. Great thing to have therapy work on. Have them come into your exercise classes. You can do some of the exercise videos, just working on that ankle range of motion and movement. That's a great intervention. Resident will work on ankle movement during exercise class. Hip range of motion. If you notice that somebody's not able to be standing upright, they can't lay flat with their hips and their knees straight, they're going to have a hard time protecting their body and preventing a future fall. Leg weakness, any of that decreased ability to sit and stand, to walk long distances. If you're seeing individuals kind of decrease the amount of time they're walking, the distance they're walking. Pain, incontinence, we talked a little bit about. Loss of balance without a fall, because you can prevent it. These individuals, we want to get them in, we want to work them up, do further assessment with them, and any change in cognition. So these are kind of key areas that we want to focus on when we're looking at what interventions might be appropriate for these individuals. So when you're doing kind of that root cause analysis, looking at, were these things potential causes of the fall? And if so, what intervention can go along with them? Cognition is a big area, especially in housing, that we don't spend a lot of time talking about in regard to falls. A lot of times when a fall occurs, we think it's very physical. A lot of times we'll recommend physical therapy, we'll recommend some changes in maybe mobility devices, having an escort from their room, but looking at cognition and talking about the cognitive changes that impact falls. And a lot of times cognition is a huge causational factor of the fall to occur before we see physical decline happening. Some of the times where you might see individuals who have had an increase in falls, or maybe when you're doing your root cause analysis to look at why they might have fallen, some of these things might be impacting it. It might be that they've had maybe a room change, or the room has been rearranged. Maybe the distance from their activities has changed, time of day when they've had meals, naps, appointments. Any changes in glasses, lighting, hearing aids, all of those things can impact cognition and therefore impact the fall risk. So when you're thinking about falls, when you're looking at what interventions do we put in place, look at these pieces also during your root cause analysis. This is just a information sheet. I will provide all of this to you guys. These are some potential interventions that we might try. And when we talk about interventions for a fall, we don't want to put in place 5, 10 different interventions. We want to put in 1 to 2 interventions. That way we can clearly assess if they're working or not. And if they're not working, we can remove them and put a different intervention in place. You know, I'm a strong component of getting your physical therapy, occupational therapy, and speech pathology evaluations in, recommending they do a comprehensive evaluation to look at falls. But we want to have something in place while those comprehensive evaluations and treatment are going on as well. So these are just some general areas we can look at, kind of based on the category that we've identified might be the causational factor for a fall. If it's fatigue, are we encouraging rest breaks? Are we monitoring sleep patterns? Are we talking with family and with the resident about, are they sleeping well? Are we looking at, is there any sensory stuff going on? If we recognize that their falls are happening a lot at night, Maybe it's while they're getting up to go to the bathroom. Is it something where we've asked family or the resident to have motion sensor lights put in for the night lights in their bedroom and into their bathroom area? Do the residents keep their glasses in a familiar place? Interventions don't have to be big and complex things. They can be very, very small, simple changes that can have huge impact. Removal of silky night clothes. A lot of residents we will find will just slide right off of their bed because they have those nice silky nightgowns on. And they'll just say, oh, I just slipped out of bed. Simple change, or at least a way to identify why the fall is occurring, and then talking with the resident, with the family about what are some potential things we can do to keep you safe and independent now that we've identified that this is a potential cause. This is just another list. Again, I will send this out for all of you guys to review, just different things that we can potentially put in place for interventions. And again, it's not where we put every single thing in place, 1 to 2, see if they work. If they do, awesome, that's great. We'll reassess them during their next kind of review period. But if they don't, at least we know we have that good documentation, and then we can say, okay, what can we try next? Some of those environmental interventions, we went over kind of those 5 simple steps to looking at environment. But this is just an environmental observation review. It can be done by any associate. It can be done by a resident. It can be done by a family member. Just looking at what could potentially be impacting falls that's an external factor impacting our tenant and our residents living with us. And then I did want to provide you guys with a couple of fall prevention resources. Falls and fall prevention it's really a big pie. There's a lot involved in falls and how it impacts not only our residents and their families, but also how much it impacts you guys as the care providers and your frontline associates. Because we know that the more somebody falls, the higher their level of care gets, the more complex it gets, and the harder it gets to keep them living in your guys' communities. And really the goal is to keep them living with you guys as independent as possible for as long as possible. So empowering our residents, our family members to take part in fall prevention, that can be a really huge, impactful thing for your community. So I wanted to give you guys some resources that are available. They're free. We have them on eSources as well. STEADY is the CDC program. It's the program that the Benedictine Fall Prevention was based through. Essentially, it's very simple practice. It's screen, assess, intervene. So simple steps, things we can do. This is one of the examples of a resident tool. So this is something that anybody in your community, whether they're independent living, assisted living, memory care with their family members support, they can look at their own fall risk and answer yes or no. And then it gives some simple information about why it matters if they've answered yes to some of these questions. And it really allows us to start that conversation with the individuals living in our community and start talking about why we want you to stay independent and why fall prevention is so key in staying independent within our Benedictine community. So this is a great way to empower your residents, empower their family members to take that active part in staying in our communities. One of the other pieces of information, I will see if I can share it on my other screen once I close this, is some of the quick screens. They can be done by any of the individuals in your community. These are all the resources for them. All of them are free resources from the CDC, so they are available for you. I'm going to end this really quick and I'll share my other screen piece so you can see what they look like. So this is the quick checklist fall risk factor. This is something that can be done as a community team. It's something that can be done by the families, by the resident. It could be provided to them to bring to their physicians during their next Medicare visit. But it goes over some of those high risk factors that we can impact. So again, fall history, always the top one. Any falls in the past year, and are you worried about falls? Again, those are the 2 biggest things that impact falls and that we can do something about. Any of those medical conditions, if you have individuals who have these, they're at a higher risk. Medications, encouraging our residents to do a medication review with the pharmacy when they go out to maybe have a prescription filled, if we're not the ones overseeing their medications, encouraging them, hey, talk to your doctor, talk to your pharmacist if you have any of these medications, and what we can do about fall prevention here, keeping you as independent as possible. These are some of the tests and assessments that the Benedictine therapy team can do and provide that information. So the tug, the 30-second sit to stand, the 4 balance test tandem, and give a good fall risk assessment and analysis specific to the individual, because it might be that we don't have to worry about the individual getting up and sitting down, but when they start walking distances, like from their room to the chapel or from their room to the dining room, that's when their fall risk goes up. So targeting when we need to worry about falls within an individual's kind of daily routine as well. Vision, are we encouraging our residents to get vision exams? Is it something where we provide information if there's a free community event, if there's a vision screen happening on our campus, do they know about it? Postural hypotension, anybody complaining of that lightness, dizziness from sitting to standing, and lying, making sure we're aware of those, and then any other risk factors that have been identified. So it's just a nice kind of checklist to help you guys talk about what should we be looking at when we're talking about falls, when we're doing our risk analysis, when we're doing our deep dive, especially for those frequent fallers, because it might be just one of these areas and then we can target it a little bit better. This is something that a lot of our therapy teams will provide to our outpatients after we see them. It's just a quick checklist for fall prevention. We give it to the tenants, the family members, encouraging them to look into their home. No reason that you can't use this as well. Talking with the family, talking with the tenants living in the communities. Have we looked at the stairs and the steps? Have we looked at the floors in their room, the kitchen, the bedroom, the bathroom, and encouraging them and giving them a solution. This is something you guys can also use if a resident keeps having a fall in their bedroom. Let's look, is there light near their bed? Is it hard to reach? If yes, easy intervention that we can put in place. Let's move the lamp closer so they can reach it. Like I said earlier, interventions don't have to be huge and complex. They can be very simple, but we want to know where to look and how to look for them. We talked a little bit about that path from the bed to the bathroom being dark. If so, do we put those motion center night lights in? Do we encourage family members to do that? Our residents to do that? If it's falls in the bathroom, let's look at the tub. Let's look at the shower floor. Do they have a non-slip rubber mat? Is it still non-stick? Is it still non-slip? Is it still in the place where it needs to go? A lot of times I will go into our resident tenant bathrooms and they will have the mats flipped upside down. So the suctions are on top and then the slippery side is on the bottom. Increases their fall risk, doesn't do what it's supposed to do. Easy intervention, flip the mat the right way. Like I said, some of them are very simple things we just don't think about, but checklists like this can help us start those conversations of things we can do for interventions, especially for those residents that we all have that really don't like to have a lot of involvement. This is something we can give them that they can review. They can have family support to look at it as well. So just some ideas to look at, some different things to review with those falls. As I said, with the Benedictine teams, making sure that if there is a fall that you want more assistance with, that you want a deeper fall analysis on, getting an order for physical therapy, occupational therapy, speech language pathology through the tenant's physician with that family and resident consent where appropriate. And they can help you make some of those discussions, do further root cause analysis. But we want to have things we can put in place in the meantime. And sometimes it's like I said, very simple intervention things. And really kind of using that checklist to see, is this a modifiable risk factor? Okay, what have we identified as this individual's risk factor versus another tenant or resident, and going from there. So I know Penny, you said you'd open for questions after. So if anybody has questions, anything they want, otherwise, I can always set up one-to-one time with your teams, talk about some of the falls happening in your communities, and doing a little bit more of a deep dive with your teams on those things.
So Lisa, I have a question that I think you you did answer with multiple ways you answered. But I'm just wondering what your first thought would be. A lot of what I see is lack of impulse control as the reason for the fall. What would be your first look in a memory care when it's just somebody who's just trying to get up when they shouldn't?
So for that, I would be looking at it from kind of a room setup and really a cognitive demand for the individual. Is this somebody who, depending on really where they are in that cognitive process, can they have new learning or not? Because if they can't have new learning, it's going to restrict the type of interventions we put in place. And a lot of times we try to put new learning interventions in place, like call for help, use your call light, or remember to do whatever it is, when that's not going to be an effective intervention. So what are the environmental modifications that we can make? Is it that the resident's bed is too high? Is it that every time a car goes by, they see light coming through their room, and maybe we just need blinds on their window? Looking at the environment of their room and seeing what are those cognitive triggers for them that might increase the falls. Attention is a huge thing when we look at the memory care units. So a lot of times when I'll start my assessments, I will just sit in the resident's room with them and see what is the cognitive demand happening on this individual just sitting here in the room. Is there external noise? Is there competing light? Is there different stimuli that they are attempting to respond to? Whether it's the TV going on, the flushing bathroom next door, the staff walking by, because a lot of times it's going to be that demand for attention and the individual having that impulsive movement to get up and see what's happening. So sometimes it's just really looking at the environment to see what is impacting their desire or their need to have that mobility. The other thing looking at is urinary urges are another thing I always want to be sure we're addressing. Is it that they feel like they have the urge to urinate? That's one that more on the medical clinical side we can address versus just the cognitive side. So it is, it is a lot of times a trial and error to figure it out, which is why I do encourage, get additional eyes in there to do a deep dive assessment. It's easy to say, oh, the resident is impulsive. Okay, but why? Because not everybody with dementia is impulsive. Not everybody with a cognitive impairment is impulsive. Very specific diagnoses are impulsive within that spectrum, but we don't want to just jump to saying the resident is impulsive, therefore they get up and fall. We want to look a little bit deeper into it.
That is super helpful. So Patty and Lisa, both of your presentations were just very much appreciated, very helpful. Think we had a good turnout today. Thank you all for being on it, and we will have the recording available for those who need it. Thank you all. Have a good day.
Thank you.
Thank you. Bye.